Hello, a very good afternoon to my fellow colleagues in Jakarta. Thank you very much for inviting me to participate in this year's JUMP 2025. It is a privilege for me to be on the podium with Professor Ricardo Campi to discuss the pros and cons for open kidney transplantation versus robotic kidney transplantation. Although I'm based in Singapore, I'm sending you this presentation and will join you from Bangkok, Thailand. I will be presenting on the arguments for open surgery. Really, the arguments for open surgery are arguments against the new kid on the block, robotic kidney transplantation. And there are five main arguments in my talk. Firstly, reported benefits over open by robotic kidney transplant is not game-changing. There is an associated prolonged anastomotic time associated with the robotic technique. There is a steep learning curve and risk in mounting it and should therefore be confined to high-volume academic medical centers. Robotic kidney transplantation has obvious high cost. And lastly, benefits in open surgery can also be achieved and improved with continued innovation. So we now know what the reported benefits of robotic kidney transplantation over open. That there are fewer wound complications in robotic kidney transplant, and there is associated reduced pain and shorter length of stay. This in turn results in lower opiate usage. Are these a game-changing and worth the increased cost and possible risk of robotic-assisted kidney transplantation? Probably not. And I deliberately use the word game-changing in comparison with other technologies such as in stone surgery. The use of suction access sheath has been game-changing as well as lower in cost. Certainly, there are also claims of improved cosmesis with the wounds in robotic kidney transplant over open surgery, and transplantation of morbidly obese patients has also been advocated with a robotic kidney transplant, and especially for BMI more than 40 as reported by the Benedetti group in Chicago. However, as we know, majority of cases that are reported are currently done with BMI of less than 30. With regards to better cosmesis over open kidney transplantation, we know that there's gradual change in the perception of transplant wounds, particularly such as the above, Sarah Hyland, who has had 2 kidney transplants, showing off her wounds in a very respectable, good-looking tummy. Such advocates by celebrities showing off their kidney transplant wounds certainly will change in the perception of how cosmesis in transplant surgical wounds are looked at. And really, in major operations such as kidney transplantation, the cosmesis of minimally invasive surgery may not be as important as surgeon reputation or complications. And this is really advocated in the UST Southwestern survey done a few years ago, which found that scar size and number of scars may be less important than surgical outcomes in surgery. Let's look at what is the evidence of robotic assisted techniques over open techniques for kidney transplant recipients. This is one of the earlier systematic reviews published in High Index European Urology in 2017. Subsequent meta-analysis and systematic reviews have been lower impact journals, but also show similar findings. That robotic assisted kidney transplant may be promising for complications and recovery, but there is low level of evidence due to the non-conformity of reporting baseline characteristics. For example, robotic kidney transplant in these studies that are collected by the systematic review excludes multiple abdominal surgeries excludes patients with severe atherosclerosis or complex vascular anatomy, and also excludes patients with advanced polycystic kidney disease. Therefore, there is no randomized controlled trial. There is no like-for-like apples-to-apples comparison. Nevertheless, if you look at this high-indexed publication comparing the open technique COKT versus robotic technique, it is clear that the open technique is performed in majority of cases with a lower operative time and better anastomotic time, which I think is also, it lasts usually about half an hour anastomotic time in open technique, whereas the robotic technique usually is much longer than half an hour and can be extending up to an hour. Of course, this systematic review confirms the benefits of shorter incisional time, length of stay, and wound complication. Anastomotic time has been the dogma of kidney transplantation, and it is clear after many reviews and analysis and different case reports, anastomotic time is significantly longer in the robotic technique, which results in the longer ischemic time. In this large-scale study from the Eurotransplant registry looking at over 13,000 kidney transplants, they found that prolonged anastomotic time increases graft loss risk, a hazard ratio of 1.1 for every 10-minute increase. And whilst it is acceptable and less than 20% for ischemic time of half an hour or so, it increases to more than 25%, 1 in 4 graft loss, if anastomotic time extends beyond an hour. Median anastomotic time in the open series is 36 minutes. And this shows that in open technique, there is an impact on anastomotic time, but open technique delivers a consistent anastomotic time over large numbers of cases. Can robotic assisted kidney transplant in a large series or numbers such as open transplant deliver such anastomotic time? It is difficult to expect. And the reason is because robotic surgery for kidney transplant has a steep learning curve. It is technically demanding surgery, and 35 cases was reported to be the learning curve by Gaglioli in a European Urology paper in 2020. However, it is important to note that these studies are performed by high-volume robotic surgeons and expert transplant surgeons, robotic users in academic centers. And although 35 cases was compared by Dr. Campi to the purported 30 cases for open series, I doubt that 35 cases really is adequate for robotic surgery for the general urologist doing robotics, because I suspect the number of cases should be much higher. And the reason why I think the learning curve is underestimated in the European Urology paper is this initial series reported by Dr. Brada Alcaraz and the Spanish team, and with very stellar robotic surgeons and transplant surgeons. In this initial series of 120 transplants, majority living donors with relatively low BMI, less than 30, they had 3 cases of arterial thrombosis. This series, therefore, results can be difficult to accept by smaller programs, where if you start mounting the learning curve, you may expect 3%, close to 3%, or if not more, because generally we are not as great surgeons as the Spanish guys or experienced. Then 3% graft loss, especially in living donor series, may be difficult to accept. Also important to note that in this initial series, there is 3 cases of ileus due to the cooling effect intraperitoneally, which is not occurs in open surgery, and that lymphocyte still can be present in the robotic kidney transplant series. So this goes back to the point of the potential benefits of robotic assisted kidney transplant may not have been game-changing as expected. And on top of that, robotic surgery will add to the cost of kidney transplant. There is no cost analysis and probably never will be one. The obvious cost monetarily to patient will be significantly higher. But the cost to the healthcare system beyond the monetary cost will be what is the impact of adopting a high-cost technology on the wait list, on the transplantation rates, especially in our part of the world in Asia. Looking at radical prostatectomy in Singapore, which is a relatively a developed country, you find that regardless of government or private ward bill sizes, the impact of robotic surgery has been a steady increase in the cost and the bill sizes of prostatectomy. This will also certainly be reflected in other surgeries, including kidney transplantation. Therefore, we have to ask ourselves, in the transplant system, will a higher cost surgery requiring a higher learning curve bring more transplants to more of our patients? This is the transplant rate. On the left is 2013 statistics, on the right is 2023 statistics. The areas in blue, which occupy most of Asia, reflects the lowest transplant rates in the world per million population. So over the last 10 years, our transplant rates in Asia remain low. Is robotic kidney transplantation the answer? Probably not. In India, where robotic kidney transplantation was also pioneered by Professor Alawat, you can see that the uptake of this procedure has not increased the number of transplantation to their population in India. Lastly, open surgery technique can also innovate. If it's a wound size that is important, you can see the Korean surgeons have developed a minimally skin incision technique for open kidney transplantation that also can minimize the wound size, particularly for low BMI patients. At our center, we have also developed ERAS protocols to reduce morbidity for open kidney transplant recipients. This includes not using double J ureteric stents, drains with a careful subcuticular skin closure, using a local anesthetic infiltration catheter to reduce the opiate use, as well as early trial-off catheter removal. We find that in selected patients with low BMI, the outcomes are good with reduced morbidity. And these improvement in morbidity with the open transplant surgery can be achieved cheaply without the use of complicated robotic instruments. Increasingly, healthcare systems are looking at value-based care to improve outcomes. That is, to achieve important quality indicators as indicators in the chart table on the right, looking at length of stay, readmission rates, reoperative rates, but taking into account the cost of delivering these outcomes. And certainly, transplantation requires a delivery of improved outcomes without increased cost. So in conclusion, I believe that open surgery remains the standard of care over robotic kidney transplantation in terms of benefit-risk ratio. The benefits of robotic kidney transplantation over open surgery is not game-changing, and there's a risk because robotic kidney surgery has a difficult learning curve. Open surgery, on the other hand, has a standardized learning curve over thousands of cases with better achievement of anastomotic or ischemic times as in all the stated by all the reviews. And it can continue to improve with low cost uh, techniques, and this achieves better value-based outcomes that's increasingly important in different health systems. Therefore, in Asian countries with low transplant rates, a robotic assisted kidney transplant is not the answer to a sustainable model to increase transplantation rates. Thank you very much for your attention.